Hi everyone, happy Friday. Um, you're stuck with me today only because Prof. is hanging out with family, but I'm very, very excited because we have a guest presenter from Portugal. Lorenzo is here from hanging out with us, and he just did a little bit of a mini intro behind the scenes, but maybe I can hand the mic to you to tell the audience a little bit about yourself.
Thank you, Ravi. My name is Lourenço Garcia. I'm a second year nephrology resident. I work in Hospital Corri Cabral in Lisbon. I was presented to the CP Solver space from a friend, Antonio Mesquita, who had presented a case in the past in 2022 to Aaron and Euro VMR. And since I love all things diagnostic reasoning and whatnot, I decided to bring you what I think it's a very interesting case.
Oh my God, what a treat. We're so excited. Thank you so much for hopping on. Um, I'm curious, what do you told us a little bit about your life in medicine. What do you like to do outside of medicine?
I used to go on runs,
Yeah.
but I've been diagnosed recently with asthma, so that's not
Oh my
nearly as
gosh.
common or as frequent as before. I love to read comic books and manga and
Ah,
watching anime.
what?
Um, Mainly that, yeah.
Oh my gosh, the mix of the indoors and the outdoors. You seem like well suited for all the sun to run and the cloud to stay indoors and hang out. How did you decide to do nephrology? What pulled you into that space?
Um, uh, Basically, we have a final exam after we finish med school to enter our subspecialties. And when I was studying, I noticed that I really liked pathophysiology that was related to renal
Yeah.
diseases with all of the autoimmune diseases. And nephrology, it has some similarities with internal medicine, whereas nephrologists usually see the patient as a whole, and
Right.
they can dabble in a lot of different pathologies that usually affect the kidneys as bystanders and not so much as the main organ that's affected.
Absolutely. Yeah, I think that's so well said. It's incredible. I'm curious, how are you so articulate in English? Is that something that you've had to do yourself, or is that part of growing up in Portugal?
Something that I've learned for myself mainly, due to my interests, whether it be watching movies or reading comic books. I mainly read in English, and I've also studied most of during most of med school in English. So
Yeah, that's really cool. I think your English is better than Prof. Rez's English, and I can't wait till he watches this recording and
he,
throws me
st
a virtual
he
punch.
still beats me in golf though.
Yeah, probably. Amazing. Well, before we get started, I want to pass the mic to the two people who are helping make this happen. The first is Kritika, who's scribing today. Mic to you, Kritika.
Hi all, happy to see all of you and very excited for the VMR today.
For those of you who are getting to know Kritika, she's preparing for an exam and yet making the time to be here today. Really appreciate it. Equally busy is Julia, who is starting a new role in a new life and yet is doing teaching for us today. Mic to you, Julia.
Hi everyone, I'm Julia. I'm starting a research. I started this weekend. So nice. I'm happy to be here today.
And very happy to have you. I feel very intimidated. You look like the CEO of the the corporation. Very glad to have you. Alrighty, without further ado, take it away.
Okay, so just as a backdrop, this is a patient I was seeing last year around October. And for the first aliquot, I have the case divided in around five aliquots in total. And we'll start with an 82-year-old male that presented to the ED with intense posterior neck pain for the past week. The patient described the pain as it started insidiously and it was progressive in nature, and it worsened with active and passive movements of the neck and against resistance, and he felt like it radiated to the right shoulder. He also reported symptoms of asthenia, fatigue, and malaise for the past 4 months. In terms of review of systems, he denied any trauma, changes in muscle strength or sensation, fever, unintentional weight loss, anorexia, chest or abdominal pain, and or urinary or fecal incontinence. And I'll stop there.
Oh my gosh, what an incredibly rich history. Thank you so much. Yeah, there's a lot to dissect here, and I think whenever we take care of patients who are coming in reporting neck pain, I think most of us have a lot more practice um, dissecting a similar space, which is low back pain. And you might ask yourself, how is it different approaching neck pain than it is low back pain. And the truth is there's so much similarity that you'll find yourself adopting a similar approach, which is often a red flags based approach. That's the case because the vast majority of patients with neck pain, just like the vast majority of patients with low back pain, have non-specific, often musculoskeletal complications in both those areas. And you will find for over 90% of those people, giving them non-specific symptomatic treatment and watching their pain go away. Now, the reason these two places are linked so tightly is is largely because they're the most mobile part of the spine and are subject to the natural forces of wear and tear. And so take neck pain in this HPI, replace it with low back pain, and ask yourselves, what would you do different? And here, if this patient were presenting with low back pain that is insidious in onset, worsened with active and passive motion in the context of malaise and fatigue for 4 months, you might have accumulated enough red flags to worry, and I certainly have. And so I'm adopting that same exact approach of asking myself, okay, is this non-specific neck/back pain? And I worry the answer is no, because of a very, very key and simple principle. The alarm flags for both neck pain and back pain all have to do with a very simple concept, though there are many red flags. And that simple concept recognizes that most neck or back pain is a local disease of local structures. However, most sinister causes of neck or back pain are actually systemic diseases that migrate to those two structures, be it a systemic infection like an epidural abscess from bacteremia, a systemic autoimmune disease like the spondyloarthropathies, or most ominously and most commonly globally, a systemic malignancy that goes to the back. You see, when we think about sinister diagnoses in patients' backs, we're often worried about these entities. And if you apply the filter of, is this a really bad local disease or a really bad systemic disease, the vast majority are actually systemic diseases. The only local disease that I know to think of is a patient with compression fractures from osteoporosis. So when you're interviewing a patient with back or neck pain, what you're really trying to figure out is this isolated musculoskeletal disease to just the back, where the patient has no neurologic or no systemic features. Those are the patients, the vast majority of them, have no red flags whatsoever. But the moment you get a hint that in addition to the discomfort in the neck or back, the patient has a parallel systemic syndrome, here the malaise and fatigue for 4 months, is the moment you should worry. So in the last 3 minutes, what have we talked about? I've tried to impart upon you the notion that neck and back pain are the same in large part. They're the same because what you are faced with in reality most of the time is a non-specific local musculoskeletal disease in over 90 to 95% of patients. All the red flags that you know and love are all trying to capture a simple concept. Does the patient have features of or risk of systemic disease, be it a risk of injection drug use, risk of cancer through smoking or family history? And here, unfortunately for this patient, that systemic fingerprint is present. What's the only real difference between neck pain and back pain? The major difference is there is no such thing as anterior low back pain, but there is anterior neck pain. And anterior neck pain is an incredibly different diagnostic space than posterior neck pain, because it really has a very limited differential diagnosis. So the only advantage of the neck is the ability of the patient to localize anteriorly versus posteriorly. That's the only difference. Here, the fact that this patient localizes posteriorly allows us to copy paste exactly what we would do with low back pain. So I'm pretty worried about this person. And in stark contrast to the vast majority of patients I see, Lorenzo, where I would just do a history exam and then discharge them with supportive care, this patient has already even before laying their past medical history or hearing their physical exam, I already know at a bare minimum I'm going to be getting some simple diagnostics based on the systemic features. Alrighty, we're an intriguing start. Mike, back to you.
Wonderful discussion. So in terms of past medical history, the patient has a known history of hypertension, gout. He had a prostate adenocarcinoma diagnosed 4 months ago in relation to October, so in July 2024, with regional lymph node metastasis, but without distant metastasis. He was planned to start radiotherapy, which he hadn't yet started, and hormone therapy with Leuprolid, which he had one administration so far at the time. He also has history of GERD, of chronic non-atrophic gastritis, a low-grade tubular adenoma that was removed in 2018, diverticulosis, and he was followed in a dermatology consult for a pruritic dermatosis with hyper IgE, with a working hypothesis of Fuji's disease, for which he was taking dupilumab every 14 days. In terms of family history, it was non-relevant. In terms of social history, he lived in Lisbon with his wife. He had no pets and no history of recent travels. In terms of medication, he was doing bilastine, mirtazapine, febuxostat, lisinopril, omeprazole, sertraline, and a multivitamin supplement. And I'll stop there.
I see the tag team scribing. It's a very, very rich case. Lorenzo, you might have to educate me. What was the dermatological disease he was diagnosed with? Sorry, I missed that.
It's Fuji's disease. It's eosinophilic pustular folliculitis.
Oh, I've never heard of it before. Fascinating. Okay.
Unfortunately, I don't have many pictures of
No, that's okay.
what his skin was at the time, but it was the, at least that, to my knowledge, it was the first case diagnosed here in Portugal
Wow.
around the same year. Yeah.
Yeah, I'll have to read more about it. I'm just making a note to read about it now for sure. Um, I'm sorry to call on you unprompted, Khasha. I see your thinking mind here. I'm curious, what jumped out to you in the medical history? What thoughts are crossing your mind in that space?
Well, the first thought was that we usually tend to have zebras on Fridays. This is a zebra that is not being presented for the essential diagnosis. But right now, I don't really have anything specific. I'm just thinking about whether the background history of this skin disease is going to be noise or signal, focusing on the possibility of autoimmunity that may have to do with something, but I don't really have anything specific as of yet.
Yeah, I mean, I think that, this is such a common medical history for people of this age that you ask yourself, is it signal or is it noise? I mean, how many 82-year-old people have hypertension, gout, and localized prostate cancer? It's very, very many. I think that the rarity of his dermatological condition definitely prompts some query, given just a lack of knowledge of how it can be related either directly itself or through the associated treatment, which I'm not sure how immunosuppressive the dapomilumab is, but it certainly would cross my mind to try to look that up. And so I think, as is true for most patients who have neck or low back pain, the main piece of history in the background that radically changes the calculus is a history of cancer. In fact, we know that a history of cancer dramatically increases the probability that a patient has a sinister cause of any central musculoskeletal concern. So here, the thing that I was looking for was, does the patient have medical history of cancer? And the answer, unfortunately for him, is yes. He has localized prostate cancer. And I think the recency of his localized prostate cancer is certainly something that counter argues him having metastatic prostate cancer, since he seems to be in great hands getting appropriate treatment. But I think you'd be hard pressed not to, at least for a moment, worry that that he had metastatic disease. Sorry, one second. I'm making a lot of loud sounds. Much better. Can now focus a little bit more. Yeah, I think yeah, it's hard not to worry about that in the background, though. I think the fact that he just got treatment and is on surveillance treatment certainly counter-argues that a little bit. The way that patients with prostate cancer are worked up to even know whether or not they have metastatic disease is a complicated conversation, but is based on their Gleason score, which is a combination of two scores that are both histologically based about how aggressive the prostate cancer is. And the more aggressive it is locally, means the more and more aggressive it is likely to be in terms of risk of dissemination. And as soon as somebody meets a Gleason score, they are, at least in the United States, are evaluated for metastatic disease. This is, of course, in a patient who is asymptomatic and doesn't have evidence of metastatic disease. And the way they're evaluated has been revolutionized by a PSA-based PET scan. So instead of using FDG glucose, what people use now is a PSA-labeled radiotracer that essentially picks up anywhere there is prostate-specific antigen. And it has facilitated the detection of metastatic disease with relative ease, near 100% sensitivity. So if this patient were cared for based on how doctors practice in this country, and this is like an ever-evolving space, so it may be with different philosophies and practices elsewhere, but he would receive a prostate biopsy. This is assuming he doesn't have any symptoms of metastatic disease, which I think is an open question right now. He would receive a prostate biopsy, he would get a Gleason score, and it takes a very, very low Gleason score not to get a PSMA PET. And so we would, in the United States, likely know if he recently had evidence of metastatic disease or not. So just to summarize the learning so far, I think remind yourself that neck and back pain can be approached identically if the neck pain is posterior. If it's anterior, it's all about the thyroid, the lymph nodes, or very rarely the vasculature like the carotid or like the internal jugular vein. Posterior neck pain, just like low back pain, fundamentally is often a local issue from local musculoskeletal disease. And so anytime you get any whiff of a systemic disease, here, based on the malaise fatigue in the foreground and the history of prostate cancer in the background, your antenna has to be up for the patient, which means that unlike most patients, you're not going to discharge them just after a physical exam. You need to do some workup, which we'll talk about somewhere down the line. And let me see if I can see somebody else. Sorry to call on you unprompted, Jillian. I'm curious, Jillian, if you, I know you're early in your medical school, and so I think you might be the perfect person to ask what you've learned so far about gout. What is your knowledge of that common but somewhat nebulous diagnosis?
It's caused by hyperuricemia. More, I guess, it's like I don't think of it as common anymore. I'm not sure why that's the case, but I guess it's quite common. I know that it presents with like the most classic presentation is that big toe pain, arthritis,
Yes,
the
excellent.
deposition of the uric acid crystals. Yeah.
Yeah, that's
I mean,
exactly
there are a
right.
number of reasons for hyperuricemia, but a lot are benign, I guess.
Yeah, you're exactly right. I think the hyperuricemia is necessary. Every patient with gout has chronic hyperuricemia. Though sometimes in the midst of an acute flare, what happens is the uric acid can be artificially low. And so you're 100% right that you need to have hyperuricemia to have gout. Interestingly, only a fourth to a fifth of people who have hyperuricemia ever do develop saturation in their synovium enough to cause a monoarthritis. And you're absolutely right. The monoarthritis is typically in the coldest part of the body, as far away from the core as possible in the first toe. Trauma in that area doesn't help either. And gosh, it is so common that I guarantee you every single time I go to the ER, 5 to 6 days a week, I will see at least one patient with gout. That being, I do work in a population that as concentrates this disease, older people who have hypertension and kidney disease. But Julian, one thing that you said is really, really key, which is that the toe is a great model of where the disease lives. It usually lives in the peripheral extremities. But one thought that should always cross your mind whenever somebody has abrupt onset neck or back pain is the possibility of crystalline disease. It's much rarer, but it's very well described with both gout and pseudo gout. Pseudo gout or pseudo gout affecting the neck is well described. It's called Crown-Dens syndrome. Gout affecting the spine is common, under-recognized, and often affects multiple spinal levels, but usually affects the lumbar spine. So part of the workup here in this patient will be at least getting a serum uric acid level, but we'll talk much more about the additional workup when we get the physical exam. All righty, Lynn. So Mike, to you.
Wonderful thoughts. So for aliquot 3, I'll give you the physical exam and the first round of labs. For vitals, the patient had a BP of 131/82, a heart rate of 67, a respiratory rate of 17, and an SpO2 of 98% on room air with a temperature of 36.5 degrees Celsius. On general examination, it looked thin, pale, and uncomfortable due to the pain. On head and neck exam, he had pale and dehydrated mucous membranes, but no palpable lymphadenopathies. On cardiovascular examination, he had a rhythmic and regular rate, no murmurs, no JVD or peripheral edema. On lung exam, normal breath sounds. On abdominal exam, he had a soft and non-tender abdomen, no palpable masses or organomegalies. And on neuro exam, he had the tenderness to palpation and percussion of the posterior cervical region on the midline, pain with active and passive neck movements with marked stiffness that didn't allow for us to do the full range of motion. Swirling maneuver was negative. Muscle strength was 5 to 5 and no changes in sensation on all limbs. He had normal reflexes and no upper motor neuron signs. On initial labs, he had an hemoglobin of 6.5, whereas 6 months ago it was 12, with an MCV of 86. His white count was 13,000 with monocytosis, 16.8%, and a real count of 2040. Platelets were on the 569,000. He had a retic count of 1.93%. With an index with a reticulocyte production index of 0.6, so low. He had a BUN of 78, a creatinine of 178. 6 months ago, it was 1.02. He had a total protein levels of 68.5, which is normal on our labs, an albumin of 26.7, which was low for our range, normal range, a total bilirubin of 0.49, an AST of 25, an ALT of 16, a GGT of 39, an ALK phos of 719, an LDH of 308. As his ions were okay. He had a CRP of 118, which is really high for our normal range, an ESR of 89, and his iron studies showed a ferritin of 3,000, a folic acid of more than 20, above the range of we could detect on our labs, a B12 level of 1,174, and a total PSA of 0.67. And I'll stop there.
I'm amazed at you guys keeping up with the scribing. This is a lot of information to jot down, so thank you. I see it's a lot of teamwork happening. Lorenzo, maybe I can just summarize the very helpful information that you shared on exam and let me know if I have things incorrect. I think the most salient thing on the exam were two things. The fact that he didn't look well systemically, he looked pale and dehydrated. And then in terms of his neck exam, we really found a lot of discomfort with ranging his neck. In terms of the labs, you found a leukocytosis, anemia, and thrombocytosis. The differential was interesting. I thought did you say it was monocyte predominant or what was the predominant?
Monocyte predominant. He had a count of 16.8% and a total count of 2,040.
Gotcha. Fascinating. And then what was his creatinine? Sorry, I missed the creatinine.
The creatinine was at the time 178 with a BUN of 78.
I see. Understood. Okay, that's very helpful. So he has acute kidney injury, and then he has, I'll summarize the rest, extreme and isolated alk phos elevation, and elevated inflammatory markers, marked hyperferritinemia, and a normal PSA. Is that right? Okay, super, super helpful. Okay, I think it's a really good time for folks to put their heads together and plot out and try to get as much juice out of this information as possible. So why don't we do like a maybe 4-minute breakout room, and then we'll reconvene to put our thoughts together. Welcome back, everybody. Anmol, I'm really curious. Did any infections cross your mind or your group's mind as a potential culprit for this presentation? Oh, I can't hear you, but it might be.
No, I just said that.
Yeah.
Can you hear me?
Yeah, I can hear you now. Sorry. Yeah.
I just said that there is a very specific question regarding infection. I had some scattered thoughts about the other possibilities which could happen, but I cannot think of any infection that can present like this. Initially, when we did not have the labs, I was also focusing on things like prostate cancer metastasizing there, causing the problem, or the Crown 10 syndrome, or things like acute calcific tendinitis. But with the labs, I think I just felt that we have hemolysis going on with uh, undercompensation from the bone marrow. That is what I could understand from the labs. And the other, I think the platelets are also indicating that we have a chronic inflammatory process going on along with the inflammatory markers. But if you ask me a specific infection, I don't think I do have an answer for that.
Yeah,
Because
no, I love it. Yeah, I really enjoyed your analysis just in general. I think it's spot on, and we'll definitely get to all of that. I only prompted infection maybe to maybe to your surprise because you're already thinking ahead. Because whenever you're dealing with a musculoskeletal concern, you really have to exonerate the possibility of osteomyelitis or an epidural abscess. I think you're onto something there, but maybe I can ask the same question to Mark. Mark, did you think of any infections that really cross your mind?
Yeah, I mean, I don't think there's anything specific about this case that is drawing me towards to an infection. I think we always have to, think about, like you mentioned, osteomyelitis, epidural abscess. I mean, a subacute like osteoarticular infection I put in the chat is usually TB, brucella, some specific endemic mycoses, and then, I guess, if you have a subacute endocarditis and then like metastatic infection to the bone, that could be more subacute, even though those bugs are more acute, like staph and strep, more acute infections. But I think we're gonna make a lot of progress based on imaging. I think I'm leaning probably not infection as the top cause, but it's definitely something we have to exonerate for sure.
Yeah, I completely agree with you. I think both of you are onto something with infection being not high on your list, but I will say that there's one test that makes infection incredibly unlikely, and that's the alkaline phosphatase. And let me just take a moment to explain that a little bit. So you really don't have to think too hard about infection beyond just being a little bit cautious of it. So here, I think Lorenzo has shared with us the power of an isolated alk phos. And in general, whenever an alk phos is not occurring with other liver enzyme elevations, before you move away from localizing it to the liver, which you would be tempted to do because everything else is normal, you have to be open to the possibility of a diffuse infiltrative liver disease. And so that looms large as a possibility still. But when a patient is presenting with a bony problem, it's tempting to move towards the bony problem being the cause. So if we take the leap of faith and say this alk phos is bony in nature, there's a little immediate disconnect. And that disconnect would be that the patient is presenting with a localized bony concern and that he is saying only his neck hurts, but an alk phos of 719 is impossible to come from just one specific bony source. So here you might wonder, wait, does the patient have a parallel hepatic infiltrative process affecting the liver itself, or is there under recognition of the sheer extent of bony disease here? So the alk phos is a game changer and certainly reinforces the notion that this is a systemic disease going to the bone, either involving the liver or involving way more bone than the patient has yet to notice or tell us. So proportion is really, really key here. But also, if this alkaline phosphatase is from bone, it represents blastic activity. Blastic activity does not occur with very aggressive lytic processes, such as osteomyelitis. It also doesn't happen with very aggressive lytic processes like multiple myeloma. It is a characteristic feature of very blastic cancers, such as prostate cancer. In fact, you can use ALK-Phos as a marker of how much blastic activity a cancer has, and calcium as a marker of how much lytic activity a cancer has. And you could plot out on a spectrum prostate cancer, almost purely blastic with extreme elevations in ALK-Phos and little to no hypercalcemia risk, and the exact opposite, multiple myeloma, a almost purely lytic disease with almost no ALK-Phos elevation and marked hypercalcemia on a spectrum. Many cancers are the mix and fall in between, but those two cancers are the prototypes of extremes. And so here, I think multiple myeloma and osteomyelitis are both unlikely because of the sheer blastic nature of this process. But we don't just have bony disease, we have bony disease with markers of inflammation, with the leukocytosis and thrombocytosis. And so the question is, we don't think this is infection, but the patient is inflamed. How come? And that's where you have to stop yourself and be like, wait, how do I know this patient's inflamed? Based on the white count? Well, the white count is monocyte predominant. What if these monocytes aren't a marker of inflammation, but a marker of abnormal cells in the periphery, and that this patient might not just have a bony disease with inflammation. He might have bony disease with bone marrow manifestations as well. And so I think the next key step is exactly what Mark said, to take a picture of why he's hurting, recognizing that he might be having disease elsewhere. So if I were caring for this patient, honestly, I wouldn't just get a CT or an MRI of his neck. I would already be inclined to get it of his whole spine, worried that the neck is just the tip of the iceberg. And I also wouldn't just be comfortable saying these monocytes are actual monocytes. The number of times monocytes represent a more diverse population of precursor cells is high enough that I'd be worried about that possibility in this patient. So two potential traps: the neck being just the tip of the iceberg, the ALK-Phos just representing bony disease and potentially also liver disease, and then the monocyte predominance not being true monocyte predominance and potentially other cells as well. So we got to really, really make sure we're solving the right problem here. All right, Lorenzo, very, very intrigued. What do you have next for us?
Great discussion so far. So just to follow through on the thought of the multiple myeloma, it can also lead to elevated ALK-Phos, usually when it presents with bone fractures, but with the disease itself, it doesn't usually lead to high turnover of the bone, so there's no increase or severe increase of ALK-Phos levels. So for aliquot 4, I'll give you some more exams, and then in aliquot 5, I'll give you the final exam that led us to the diagnosis. So with the disparity of levels in his CBC, we did a peripheral blood smear, which showed no significant morphological changes. We did a serum protein electrophoresis with a biclonal spike in the gamma fraction, an albumin to globulin ratio of 0.6, which was decreased in our lab, an IgG of 19.8, which was increased, an IgA of 13.3, which was also increased, and an IgM of 128, which was normal, 1.28, an IgE of 6,094, which was increased, and kappa and lambda light chains of 7.52 and 4.02 respectively, with a ratio of 1.87, which was normal. Serum immunofixation showed a monoclonal component of IgG kappa type with 2 electrophoretic mobilities. We did a UA, which was bland. He had a UACR of 50 milligrams per gram and an UPCR of 70 milligrams per gram. In terms of viral serologies, we did HIV, Hep B, and Hep C, which were all negative. We did blood cultures 2 times, which also came back negative, and a negative urine culture. On lab reevaluation, we noticed that his thrombocytosis kept rising to a maximum of 900,000 and an ESR that rose to a maximum of 120. Next, we did a CT scan, a full body CT scan, which showed liver with steatosis with no focal lesions, discrete splenomegaly. He had prominent mediastinal and lumbo-aortic lymph nodes with small millimetric iliopelvic and external iliac adenopathies. His prostate had a transverse diameter of 43 millimeters, and in terms of bone evaluation, he had marked degenerative changes and several subchondral densifications of the bones of the pelvic region with no apparent blastic lesions. And we finally did a cervical MRI, which showed paramedian disc protrusions on the right, causing reduced permeability of the perimedullary CSF space, predominantly at the levels of C5 and C6, and a probable space conflict with the C6 and C7 rootlets on the right. And I'll stop there. You're still muted, Rabih.
Sorry about that. Yeah, just to maybe take a breath and help folks catch up with the scribing. I summarize that we essentially found a monoclonal protein, two of them, of the IgG type. I forget, Lorenzo, how high the IgG kappa was. Do you remember the grams per deciliter amount?
I have the IgG levels
Yes,
itself. It
I
was
see.
19.8.
Gotcha.
IgA was also elevated, and so was IgE, and I have the kappa light chains and
I see.
lambda light chains
Understood.
levels, which were 7.52 and 4.02, slightly elevated, only marginally,
Gotcha.
with a ratio of kappa light chains was normal.
Yeah, the ratio. So what we measured here is a serum free light chain ratio, which is in the normal range. It sounds like we don't have the exact amount of the monoclonal protein, and the reason and that's on my mind is that by the time that you're 80, you're allowed to have a benign nevus of your hematological system, meaning you're allowed to have a monoclonal protein that has no significance whatsoever, called monoclonal gammopathy of uncertain significance. And a very specific criteria must be met, which is that monoclonal protein has to be IgG, which is this the case, but it also has to be a small amount, meaning that it has to be less than 1.5 grams per deciliter. And so here, I think with the information that we have available, the question is this protein of significance or not? And if we tweaked this case to make the patient have normal platelet count, normal white count, a deep anemia, and a minimal or absent alk phos elevation, your pretest probability of multiple myeloma would be high enough that you would probably take this information and proceed further with it. But the knowledge that many patients have monoclonal proteins of uncertain significance leaves you cautious about whether this data is in fact signal or just a distractor. And that's where I think what Lorenzo was emphasizing, the serum free light chain ratio is of tremendous value. Because in the vast majority of patients who have a monoclonal protein of significance, they have a perturbance, an extreme perturbance in either the kappa or their lambda. And the fact that this patient's ratio is preserved is very reassuring and suggests that the amount of paraprotein here is of minimal significance. And so we'll keep that in our back pocket because that may change. And then, sorry, do you mind just one more time? I heard some very interesting things on the CT that I wasn't expecting. I heard the patient has splenomegaly, but I missed and I heard the patient has splenomegaly, had disseminated lymphadenopathy, but I missed the signature in the bones. Do you mind just outlining it one more time?
So in terms of bone evaluation, he had marked degenerative changes in several subchondral densifications of the bones on the pelvic region.
Gotcha. But he had no lesions in his he had degenerative changes, but no space occupying lesions in his bone. Is that correct?
That's correct.
Oh my gosh, Lancho, what a twist. Here we are thinking that this person is going to have bony disease elsewhere. He has none. Oh my gosh. By the way, you have such a poker face. I love it. So authentic to the exercise and with no hints given. Yeah. Okay. Um, I think there's only one right way to do this, guys. We have to go back into breakout rooms because this is a plot twist like no other. So let's just do another 4 or 5 minute breakout room, and then we'll reconvene. We have to talk about this data. Okay, see you all soon. I hope you guys had as much fun as I did talking with Nar here. But Lorenzo, this case will go down in living memory in my mind because it breaks my favorite rule, which is that when a patient comes in, they're often telling you exactly where the problem is. And so we were focused on this patient's neck hurting, and all we found is the patient has a disc protrusion. Nothing to do with the more ominous symptom. And the more ominous symptom of this patient have a systemic disease as evidenced by malaise or fatigue. And you taught me to really just respect a big, big, big thing I often just assume, which is a patient with back pain and systemic features, that the systemic features must be going to the back. But I think you're teaching me and probably many other people such a precious lesson that that's an assumption, that the back may still, the prevalence of non-specific mechanical back or neck issues is so high that even if a patient does have a systemic disease, that the systemic disease and the back pain may be true, and unrelated. And I think that for me is the most humbling lesson of all, let alone the incredible exercise we have to do now of understanding what the problem is. But I think you can actually collapse the problem into one word, and that one word is space occupation, that there is something taking up space. And we obviously see that the problem is taking up space in the spleen, making it big. And we obviously see that the problem is taking up space in the liver, causing the alk phos to elevate. And let's just spend a moment on that latter thing, which is the fine-tuning and ironing out our approach to an isolated elevation in alk phos. So whenever you see an alk phos along with other hepatocellular enzyme elevations, it's a very fair assumption to make that the alk phos is coming from the hepatobiliary tree. And so only when it's isolated do you open up the possibility that you should go somewhere else, usually the bone. But as I said earlier, you have to have the caveat that diffuse hepatic infiltration may be fooling you. And so here, what has happened is we have now isolated but subradiological elevation in alk phos, meaning we have no evidence of radiological disease in the bone or the liver. So what do we trust? There are two diseases, one in each category, liver and bone, that cause subradiological alk phos elevation. The bony explanation for an isolated subradiological alk phos elevation is osteomalacia, where the patient has really poor bone mineralization and causes alk phos elevation. And we've had 2 or 3 cases of this entity on VMR. Here, there is no evidence or reason to have osteomalacia. So I'm worried that the alk phos elevation represents diffuse infiltration of the liver. So that's that. The spleen, understanding the spleen better. So Vinny, my friend, I'm curious, what do you expect to happen to the platelet count when the spleen gets big? What should happen to the platelet count? High or low in general?
I think low because there will be sequestration, yeah.
Exactly. So now, stay with me. This patient's platelet is going up, and yet the spleen is getting bigger. What's happening?
The patient is on a chronic inflammatory state, and there's other signs of inflammation also, and that could be reactive thrombocytosis, but I don't know.
I think that's probably the most likely explanation, Vinny. But let me tell you that we don't know if the spleen is big because it has more spleen. It could be big because it has something else. And when the spleen enlarges as a result of an infiltrative process, there's actually less spleen, even though it looks big. So if you biopsy this spleen and you realize it's full of blank and not spleen, then the platelet count will go up. And so here I'm wondering about that possibility because you're getting a fingerprint of disease infiltrating the liver. And the question is that same exact disease infiltrating the spleen and infiltrating the lymph nodes? So it's a little bit of a tense situation about what to do here, but the reality is I think there is something that's taking up space, crowding the biliary duct cells in the liver, and potentially crowding the spleen, forcing it to release the platelets that would have otherwise been in it, and certainly crowding the lymph nodes. There's one other team member we haven't heard with, so I'd love to ask David. What are you thinking so far, David? What are your thoughts about what this might be?
Yeah, I don't know, because I think still I don't have a clear understanding of the problem. But yeah, my mind was thinking mainly if there is really no bone involvement, like no structural or macroscopic bone involvement, or is it just that we're not seeing it? I don't know if a bone scintigraphy or another test would um and I think I don't know, but likely there's a like feature of um liquid malignancy here, also
Yeah.
with the B12 elevation that can be a acute or more chronic acute phase reactant, but usually in my experience related to liquid malignancies and also mild LDH elevation. I think, yeah, I think a bone marrow biopsy would probably help.
Yeah.
But yeah, it's like great case, Lorenzo, because very unusual to reach this stage of the case and don't know clearly what is happening. So yeah, great case.
Yeah, I agree with you. You have to have, David, I completely agree with you. You have to have a best guess formulation here. There's no right formulation. I think tissue is the issue. And the question is, what will the tissue show? And for me, if I'm making an educated guess based on pretest probability, I think I worry that the disease is taking up space in the liver because I trust the CT. Although you're right, the CT is not perfect for sure. But the MRI of the neck where he's hurting doesn't show any bony disease at all. So I'm trusting that. And so now I'm like, wow, the liver's taking up space, alk is high. The spleen is taking up space, the platelets are skyrocketing. So there's something infiltrating both. And so what infiltrates? I think as a general principle, if you want to simplify what infiltrates, there's really two simple words. Infiltration, three simple words by cancer. You already said that. Infiltration by granuloma, which may be cancerous. So Hodgkin's lymphoma does both a cancer and granuloma. And then finally, amyloid. And I think that's where the paraprotein here is of relevance. And so I think tissue is going to be the issue here. If I were to make an educated guess about what this is, I'll just throw it out there for the sake of time. I think trusting that this patient is getting excellent care has me wondering about the possibility that this disease is abrupt and explosive in onset and very, very fast. And whenever you have abrupt, explosive onset in those three categories, which is cancer, granuloma, or amyloid, none of them are usually very fast unless you have drug-induced sarcoid. So I've actually come across a couple of cases of dupilimumab-induced sarcoid-like reaction, which is a thought that's crossing my mind. But ultimately, I think tissue is the issue here. We have to really figure out what's taking up space in the spleen or the liver, or potentially, as you said, David, in the bone marrow. So, Lorenzo, on the edge of my seat here, very, very curious what you all did next.
Brilliant discussion. Thank you all for the wonderful thoughts. Just like you all, since the ALK-phos was isolated in terms of elevation, we thought it was also coming from the bones. But since the CT scan and the MRI of the most painful area showed no bone lesions, we decided to do a PET scan. And we also sent a blood sample to an external laboratory to to measure isotypes or isoforms of alk-Phos. And since it can come from a myriad of organs, mainly the liver, the bowels, placenta, and white blood cells, mainly neutrophils. And we also did a bone marrow biopsy. So the alk-Phos isoforms assays showed a bone alk-Phos of 0.3%, which was decreased, a liver alk-Phos type 1 of 64.9%, which was normal, and a liver alk-Phos isotype 2 of 24.8%, which was increased. The PET scan showed vasculitis of large medium caliber arteries of the aorta, carotid, axillary, iliac, and femoral arteries, and of the celiac trunk. Lymph node activity of varying intensity in the aforementioned supra and infradiaphragmatic nodes, and diffuse non-specific increase in osteomedullary and splenic metabolism. And the bone biopsy actually, the first one that I'm going to tell you about, which was done last year when we first saw the patient, showed hypercellular bone marrow with increased myeloid series, trilinear hematopoiesis with maturation, increased myeloid to erythroid ratio, mild dysmegakaryopoiesis, no evident vacuolization of myeloid or erythroid precursors, increased CD34 blasts with heterogeneous distribution, around 2 to 5% of cellularity. The bone marrow smear showed 4% blasts with slight percentual increase in monocyte cells. We sent a genetic panel for MDS and MPN, which came back negative. We did a flow cytometry of the bone marrow, which showed 6.5% blasts, 89% CD13 positive, 87% CD33 positive, and 3% pro-monocytes. And I'll stop there. And the last aliquot will reveal the final diagnosis.
Oh my gosh. So this is absolutely fascinating. I think we probably didn't have the opportunity to capture everything you said on the board, but that's totally okay. Wow. I mean the value of the PET scan here cannot be emphasized, and the sheer amount of vasculitis the patient has is fascinating. I will just talk really quickly because I want to have the learning from you. It's very helpful to classify vasculitides as a pure vasculitis versus a vasculitis with extravascular features. Most vasculitides that we think about are pure vascular diseases, INCA, PAN, so on and so forth. Here, there's such a prominent extravascular feature. And that extravascular feature is a significant infiltrative and reticuloendothelial phenotype. And so my mind is now cross-checking what are the things that exist in the world of vasculitis and a hematological fingerprint. Here, the spleen, the liver, the lymph nodes, and as you said, the bone marrow. And there are two reflex considerations. One is increasingly popularized and more and more famous, which is VEXAS syndrome, a condition that I think an 82-year-old man is particularly at risk for, and actually bridges many of the things that you've outlined so far, including mysterious and nebulous cutaneous manifestations, paraproteinemia, hematological perturbances, and of course has a deadly progressive vasculitic syndrome. And the UBA1 somatic mutation would be key to clinch that. And I'm not sure if that's part of the MDS and MPN workup that you've already done, but that's certainly something that's crossing my mind. Another really important and under-recognized and hard to diagnose entity that also spans the universe of vasculitis and hematological diseases, CMML, chronic monomyelocytic leukemia, a disease which the patient is at risk for anytime they have monocytosis, and characteristically has a prominent infiltrative phenotype, infiltrating the skin, the gums, and actually has a strong propensity to cause a peri-aortitis and large vessel involvement. So I didn't catch the details of the hematological data that you analyzed, and those two conditions might have already been exonerated based on that. But they're the only two conditions that I can call upon reflexively that might meet this. And if I were to be even earnest and push myself to my absolute limit, I would say here that even though VEXAS is increasingly diagnosed and under-recognized, the monocytic nature of the CBC had me very curious whether this is a very sneaky and aggressive presentation of CMML. But I'd love to learn from you and learn from this case with the time that we've already consumed. So I'll stop there and hand the mic to you.
So just to recap, all the changes that were observed in the bone biopsy, in the bone marrow, we essentially saw that there were a mild percentage of blasts in the bone marrow. We consulted hematology, our colleagues from hematology, and they told us that this most likely was reactive at this time, since there was giant cell arthritis, a possible diagnosis of a giant cell arthritis in relation to what we saw in the PET scan. So with this in mind, we suspected of GCA, and we started the treatment with prednisone 60 milligrams once a day with taper. Afterwards, once we saw a clinical improvement, what we were not expecting was that the pain and the inflammatory markers were going, even though they were going down, later the CBC wasn't resolving. He still had the profound anemia. His monocytosis kept growing, and his platelets also were elevated. And we did a second bone marrow biopsy and bone marrow smear earlier this year in 2025, which showed an increase in the number of blasts to around 30%. And we also sent blood for VEXAS syndrome in Porto. That's where they do it, and it came back negative. So in summary, the patient was diagnosed with GCA and associated CMML that was found out in the second bone marrow biopsy that showed a proliferation of 34% blasts and an increased amount of monocytic cells that were only present in the bone marrow.
Oh my gosh. Oh, I've dreamed of this day, Lorenzo. I saw CMML do something very, very similar in intern year many, many, many years ago. And it struck with me about how sneaky and devastating it was. I think this is just a matter of intellectual adjudication. In my case, the experts felt that the vasculitic syndrome, so we actually did a biopsy of the temporal artery in my case. I'm curious if it happened in yours. And they proved that actually there was no histological features of GCA, that it was all monocytes infiltrating the blood vessels. So in our case, it was felt to be a case of pure CMML. But I also know that these hematological conditions can trigger a parallel autoimmune process. So I'm curious what your take is on the strength of the evidence for giant cell arteritis as a separate entity, of how you are juggling with that element, but also just your reflections on this very, very interesting case.
Thank you. Maybe I didn't make myself very clear with all of the data that I was throwing off.
A lot,
So yeah, our first assumption was that it was a GCA. Initially, we also thought of another working diagnosis of polymyalgia rheumatica, with the distribution of the pain to the neck and to the right shoulder, and the very high inflammatory fingerprint to the disease. And the diagnosis itself was presumptive. We did treatment, and with a good therapeutic response, we assumed that the diagnosis was correct. What we found out to be strange was the fact that the CBC kept getting worse 6 to 7 months later, and the patient still had B symptoms. It had a very high consumptive state. With now, initially, he didn't present with the weight loss, but he started losing weight. He started having night sweats and lots of fever without infection.
Yeah. Yeah.
In terms of what you just said, Ravi, sorry to interrupt you. We also thought of that. So our first impression was that it would be or could be a Vexus syndrome. But since the genetic test came back negative, we then read about the fact that CMML also causes or can present in most cases with very miscellaneous autoimmune presentations or manifestations, and the GCA can be one of them. Either GCA induced, CMML induced GCA or infiltration of the monocytes in the vascular tissue.
Yeah, perfect, perfect. That's such a great your explanation alone, let alone how you took this case and constructed it, is a marker of very, very skilled physician. It is your current and future patients are very, very lucky to have you. And I think I think now I recognize what you mean about the nephrologist having a systemic gaze, because your gaze is certainly very comprehensive and very thorough. I feel I could have timed my discussion a little bit better so that we weren't rushing out of time, because this case deserves to be stewed in. But we'll do that. We'll do that internally for sure. I just One element I want to emphasize that you really allowed us to do, which is to learn about really rare and esoteric things. But I think one of the challenges of diagnosing real life esoteric things is the knowledge required to even think of them, but also the challenge that we're faced with by putting away things that are fairly common. And I think here we had to put away the neck pain, at least to some extent. We had to put away that the patient has prostate cancer. Both things are so common that they can easily stand as innocent bystanders to a relentless disease. So I think that aspect of things is very, very, very difficult in real life. But ultimately, the most precious lesson for me is to take that CBC with a tremendous amount of scrutiny and say, is the CBC reacting to something, or is the CBC the problem itself? And from the very get-go, when you said monocyte predominance was a really important moment for us, because it's a moment that tempers the enthusiasm to say this CBC is reacting. And as it turns out, ultimately the CBC is the issue. So I think it was a really powerful illustration of that. Before we hand the mic to Julia for the teaching points, I'm curious if there's anything that you wanted to emphasize, Lorenzo, from your experience in this case.
Just some things that I've learned through here and through working with my team last year was the fact that we have to have powerful clues that we have to latch onto to further pursue a diagnostic or a diagnosis. For example, in here, we really thought that ALK-Phos was the main determinant that we thought was weird enough for the case to be not just prostate cancer metastasizing to the cervical spine, or even the explained by the herniated disc, and the fact that only later did we thought that the monocytosis was really strange. Did we put those two together and we tried to make a diagnosis around those two changes, essentially.
I will leave it at that. Absolutely superb. Thank you for a legendary case. Oh, I will remember this day forever. I've been waiting for it for 10, 11 years, honestly. Alrighty, Julia, mic to you.
So I will try to be quick to respect everyone's time. So we had this 82-year-old male presented with neck pain. So the first thing that we approached was the neck pain, as Rabih made in discussion. So the most of the neck pain is caused by non-specific musculoskeletal pain, and we have to differentiate between anterior and posterior neck pain. Posterior can come from musculoskeletal disease, and anterior most likely not. So the most likely neck or back pain can occur because of local problems, as I mentioned, musculoskeletal. However, some of them can occur because of systemic disease, such as malignancy, infection. And in those, we have to think about some red flags. And particularly in the neck, there's difference between anterior and posterior. So going on to approach to past medical history from this patient, there are some features of autoimmune disease versus malignancy, but what is most important here is the history of prostate cancer that increase the possibility of systemic cause for this neck pain. And if this patient had a most aggressive locally prostate cancer based on Gleason score, this patient will have more risk of aggression from systemic disease. And also, Rabih mentioned about gout, that is a very common disease characterized by hyperuricemia, most common in the first dose. So going on for the labs that we find some white blood cell elevation that could be for an infection. For example, when we are dealing with musculoskeletal problems, this could be an osteomyelitis. And also one important thing here was the alk phos. If elevated with liver function test elevation, this could be because of infiltrative liver disease. But when we have an alk phos elevation alone, this could indicate a bone problem. And here we can differentiate multiple myeloma from prostate cancer. So multiple myeloma is a lytic disease. It can cause no elevation of alk phos and elevation of calcium. In other hand, prostate cancer is a blastic disease. We have elevation of alk phos and normal calcium. And in this case, the normal ratio of FLC goes toward multiple gammopathy of undetermined significance. And in the end, we have the image that was a surprise for all of us because showed isolated but subradiological alk phos elevation that could occur in osteomyelitis or diffuse infiltration of the liver. Also, we see elevated platelets with splenomegaly that could indicate infiltrative disease from spleen, liver, and lymph nodes. And with the image from vasculitis, this could be like some pure vascular disease versus extravascular disease, but in this case, this endothelial phenotype and all of that goes towards CMML or VEXA syndrome, that are the two differentials most likely in this case. And the final diagnosis was CMLL with GCA that was very rare diagnosis. And I think that that's the teaching point for this case. Thank you, everyone.
You like literally absorbed everything. Everything that you said was the key learning points, and you said them very accurately, which is hard to do in a case that's flying this fast. Thank you so much. Lorenzo, I really, really hope you come back very, very soon and join us regularly. It would make my day. I think it would be really cool if next time you present to Reza and me that you present just a simple UTI, so Reza can really, really feel how much he missed out, how he missed out today. Thank you all.
Thank you.